Yeah, good evening, ladies and gentlemen. It's a warm welcome to all of you for this session on blood and blood components. Dr. Nikitha, first year resident, will be giving the presentation, moderated mainly by Dr. Nishant, who is my colleague consultant at SHRC. It goes without saying that surgeons must be very well versed in this topic. It's an extremely important topic, and I'm sure we will cover all the important and practical aspects that surgeons should know about blood, its components, and the way it is used. We are particularly pleased and happy and privileged to have Dr. Ashok with us today. He is the hematologist, the person who runs the very popular and, what I can happily and very easily say, one of the best blood banks in town. Sagar has always been, over the years, known for its blood banking and its service to its surgeons. And we have all been beneficiaries of that. Welcome, Dr. Ashok. From time to time, from time to time, we will be looking to you for giving us practical tips. And
Sure.
The perception of what surgeons should know about blood and what a hematologist or a blood bank person would want the surgeons to know about blood and its components may differ a little bit, and we're really looking forward to your inputs in this. You are welcome to raise your hand and correct us or add to whatever the presenters are going to say. And even if that doesn't happen, we will pick your brains from time to time. Welcome,
Sure,
Ravi. Ravi is also here. Ravi, as you know, is the head of the department. He's also here.
Good evening, sir.
Good evening, Ravi. So over to you, Nishant. Please start the proceedings. Yeah.
Thank you so much, sir. I think sir has given us all a wonderful introduction, and so let's not waste any more time. Like sir said, it's a very, very important topic, which as surgeons you should be very well versed with. Nikitha, please take over, Nikitha.
Yes, sir. Good evening, everyone. Today's topic is about blood and blood components. So, one second, sir.
Click on the slide once, it will get activated, and then you can start moving it.
Yes. So the word blood is originated from Proto-Indo-European word, which is blur, which means to swell or to burst out. So the people generally thought that whenever we prick something or any cut happens to a person, they used to bleed out. So we were completely filled with blood, like a balloon filled with a fluid. So it was named after such an assumption, blood. And but most of the terms in our education, I mean, in the medical field, medical language, we use the word heme or heme. I'm sorry. So, hemoglobin, hematology, and everything which is associated with the word heme. Blood is the living fluid in the body. It is the only fluid connective tissue. It's like a most important thing in the human body. So today the session, the journey in today's session is through these 5 topics: the composition of the blood, the functions of the blood and its components, and the products which we are mainly focusing on, and the guidelines for the transfusion of those products, and there is special protocol for transfusion of those products. So composition of the blood on a macroscopic level, it's just formed elements in a fluid plasma. So the formed elements are again further can be classified as red blood cells, white blood cells, platelets, and the fluid is nothing but plasma with components like it does contain it does contain ions, water, gases, and other compositions. So macroscopically, the color of blood can vary from black to red. So we generally see the shades of red depending upon the hematocrit present. So the viscosity of the blood is a major important thing, because it is most important for peripheral vascular resistance, and it regulates the flow of blood through the blood vessels. So though it is not very much related, can anyone tell the taste and smell of the blood on a general basis?
Let's start with Praveen. Praveen, do you know the answer? If Praveen is not there, next Vinod.
No, sir, I don't know. Sir.
Indraja, Pavan.
Sir, I don't know, sir.
Okay. Nikitha, please go ahead with the answer.
Yes, sir. The taste is very salty because of the presence of sodium, relatively higher than other ions, and the smell is metallic smell. They compare the taste of the blood to a salted caramel. And so macroscopically, when we leave the blood after after removing a sample from the human body, and if we leave it without any intervention, it settles down into three different compositions based on the specific gravity. So the bottom part, the bottom part is filled of red blood cells because of the higher specific gravity, and the middle layer is called buffy coat, which contains white blood cells and platelets, and the upper part is of plasma. I would like to question the value of specific gravity of blood.
Okay, Vinod, you're the only one. Oh, Vinod, Pavan, and Indraja.
1.05, sir.
Specific
Nikitha,
gravity of water itself is 1 man.
Hmm.
How can blood be 1.05?
Give the answer and go ahead, Nikitha. As in, we have more important topics to discuss on the
Yeah.
Yes, sir. Yes, sir. It's actually red blood cells is 1.09, sir, whereas white bloods are 1.03 and plasma is 1.02. Yes, sir. So this is what happens when they settle down. But after the formation of clot, the blood separates into serum and blood, clotted blood. Most of our laboratory examinations are based on the serum rather than of plasma, because it is what it is what that contains which the relevant required components which you are supposed to examine. So the basic composition of plasma is water.
Nikitha,
Most of it is
1 second. I just have a small question for you. Can you just go back one slide? Back one slide. In the second image on the right, why is there no buffy coat in this image? Why is there only clotted blood and serum?
Sir, clotted blood also traps the white blood cells.
Correct. Because the
In the network.
platelet is a very important factor when it comes to clotting of the blood. Go ahead, go ahead.
So the composition of plasma is mostly of water, and then ions like sodium, chloride, potassium, which we generally see, and proteins like albumin and globulin, and other nutrients and waste like nitrogenous waste, and gases like okay. So this will give a clear picture of the components what are present and the proportion of the components present. So the cellular component is 45%. In that, the majority of red blood cells, as we have seen in the picture before also. White blood cells is around 1% in the 45%, and platelets are very minor. even you can see the water component is very high in plasma. The proteins are 4% out of the 55%. So this picture generalizes the size of the cellular and the protein components present in the blood. The WBC being of the higher size and the components of the plasma being of lower size. So this again provides the same data with a very clear picture of the percentage by weight. So when we talk about functions, the cellular components, the function of erythrocytes, as we all know, is the transport of oxygen and carbon dioxide. The leukocytes being of defense and immunity, and platelets for blood clotting. The function of plasma, water carrying the solvent of other gases, and salts for osmotic balance and buffering, and nerve and muscle function, and plasma proteins of osmotic balance and pH buffering, fibrinogen for clotting, and immunoglobulins for immunity, and other substances which are required on a daily basis for any cellular metabolism, and hormones. So this is regarding the composition. I would like to talk about the types of products which we use on a regular basis. They are basically classified into whole, components, and derivatives. Whole is nothing but the whole blood which we take from a donor. The components are is a substance which is being separated or processed from the whole blood, and the derivatives are mainly the plasma derivatives which can be done in a which are separated or done prepared in a pharmacological setup. So, the components are also of three types, that's cellular components, plasma, and plasma derivatives. So this picture gives a wide idea about different types of components being separated from the whole blood. The whole blood has cellular components as well as plasma. After processing it, we get PRBC, packed red blood cells, and platelet-rich plasma. When it is further processed, we get plasma and plasma concentrate. This plasma is nothing but the FFP, fresh frozen plasma, which we use. And after thawing, we can separate it into a cryoprecipitate and cryopoor plasma. So this gives the technical picture of the same idea, which shows the way that thing is being processed. Here, light spin and heavy spin are regarding the centrifuge. So you can see after light spin, we get the platelet-rich plasma and packed RBC. After heavy spin, we get platelet-poor plasma. Platelet-rich plasma is further centrifuged to get cryoplatelet, and platelet-poor plasma, that is fresh frozen plasma. After thawing, we get cryoprecipitate and cryopoor plasma. The whole blood, when it is, this is by another method, Buffy coat method. After heavy spin, we get packed red blood cells, platelet poor plasma, and after light spin, we get platelet concentrate and Buffy coat, which is being discarded.
Yeah, one second, Nikita.
Yes,
Before you go there, can I get Dr. Ashok into the picture to find out what method is being used in Sagar, and if you can just sum up whatever slide you have done. Can you just go back one slide, Nikita?
Yeah. Nikitha, go back one slide.
Yes, sir.
One more slide. Yeah. So in Sagar Blood Bank also we are using the same methodology. We are also centrifuging. Usually either we will use double bag or triple bag. When we use triple bag, so initially the whole blood is collected, then the whole blood is centrifuged. Initially same, as she mentioned, platelet rich plasma is separated. First in first centrifuge, what exactly happens is usually the red blood cells and platelet rich plasma is separated. So this platelet rich plasma is transfused to another bag, that second bag, and this first packed correct cells, it is separated from the triple bag. So next step is this platelet rich plasma is again centrifuged. Then what happens? Platelets are getting separated and plasma, that is platelet poor plasma. So platelet poor plasma will remain in the same bag and platelets are transfused to another bag. That is called as random donor platelets. So then that plasma, which is platelet poor plasma, is either stored as fresh frozen plasma or thawed at 4 degrees Celsius to prepare cryoprecipitate. So this is the same procedure or same methodology is used in Sagar Blood Bank also.
Yes. How long does this entire process take?
Usually after collecting blood within 6 hours, we have to separate the components. So usually within 6 hours means usually entire process will take only around 1 to 1.5 hours.
Ashok, the single donor platelets, how is this one? You directly take the blood and remove
Yes,
the
sir.
platelets.
Yes, sir. Single donor platelet is totally a different procedure. So here, where the donor is directly connected to a apheresis machine. So where the machine will collect patient donor's whole blood, it will separate only platelet. Rest of the blood components are retransfused back to the donor.
Okay, and it doesn't do any harm to the patient.
No, sir. No, sir. Nothing.
Red blood cells getting destroyed or anything like that.
Nothing will happen. Sir. Nothing.
Okay.
Yeah. Thank you so much, Dr. Ashok. Yeah. Any doubts from the PG so far? Vinod, Pavan, Indraja.
Sir, thawing means I'm not able to understand. Sir, the thawing means.
Thawing is usually the FFP, fresh frozen plasma. Usually it is stored at minus 80 degrees Celsius or less than minus 20. So here we have to bring the plasma around 4 degree to 6 degrees Celsius temperature. Then we have to centrifuge. Then whatever the precipitate obtained is cryoprecipitate.
So basically, Pavan, it means that whatever is frozen, you're slowly
frozen. That is yes.
In your fridge, if you remember, there is a defrost button. This is something similar to that.
Something like that. Yes.
Okay, sir.
Yeah. So any comments from the senior, sir? Ravi Shankar sir, Lakshman sir?
No comments. Please carry on.
Yeah, please carry on, Nikitha.
Yes, sir. Actually, they do have a water tank in our blood center, sir, which is used for thawing. They place the FFPs in that water and allow it to thaw, sir. I included that picture also.
How long does it take, ma? To thaw?
Sir,
20 minutes, sir. 20 minutes.
yes.
Yeah, around 20 minutes to half an hour.
Yeah. Go on,
Ashok,
Nikitha.
one more
Sorry.
question, Ashok. Sorry.
Okay.
When you, for example, if we need white cells only,
Okay.
how do you do that?
In our blood bank, we are not doing that. Same like platelet pheresis, we can use same procedure can be used to separate white blood cells. Only thing is we have to fix this one software setting in the machine. That's all. Then instead of platelets, these white blood cells will be separated.
Okay. Because I
Same.
think in patients who have, severe
Yes, sir. Neutropenia. Yes.
with severe sepsis, before we, giving the granulocyte colony stimulating factor and all that, before
Yes,
that
sir.
works, sometimes we may need to transfuse white cells.
Same apheresis machine can be used.
Right.
So
Okay. Yeah.
the
Thank
present
you.
machine, what we are using, the software is designed to separate only platelets. So
Okay.
if we can change the software design to collect granulocytes, we can collect.
Okay, thank you, thank you. I didn't know
Yes.
that.
Thank you, sir. Carry on, Nikita, please.
Yes, the whole concept behind trying to get the components of the blood instead of giving the whole blood. So it's basically when a person is under is having a requirement of transfusion, most of the times he just requires a part of the blood rather than the whole blood. So in order to meet his needs and also to decrease the misuse or improper usage of whole blood, we are breaking down or making the whole blood into the components. So
To make it much easier for you guys, if it's one whole blood, it can be divided into RBC, platelets, and plasma, through which you can treat 3 people who have different needs. Rather than being misuse of one product, it's just that one component, one whole unit of blood can be given to multiple people. So with less amount of blood being taken out from a patient. Carry on, Nikita.
yes,
Nikitha,
And
can you?
one more point is it avoids volume overload also.
Yeah.
That is one more important point. That's why only the components are transfused. Yeah, carry on.
Nikitha,
sir.
one situation where whole blood is transfused.
Sir, in case of heavy, like massive bleeding, sir, from a person or active bleeding, I mean, sir.
Yeah. But where usually? Because even with active bleeding, you only give packed red blood cells. And plasma, of course, later. There is a formula for that. But in certain situations where you have no choice and you don't have a sophisticated blood bank to do all this work for you, and then probably there is no time.
In a mass casualty, when you don't
mass
have,
casualty war settings where blood is required in the field, battlefield, you can't have a blood bank to do all these things, or it may take time and some patients may need, so you then just quickly cross match and then transfuse them. So that is the only indication now for whole blood transfusion.
Yes, sir. So the whole blood is we collect around 450 ml of blood, which is mixed with 63 ml of anticoagulant. This is normally considered as 1 unit. There is also a 350 ml of 350 ml unit, which includes 49 ml of anticoagulant. It is stored at 1 to 6 degrees centigrade, and the shelf life, depending upon the use of depending upon the specific anticoagulant, it varies up to from 21 days to 42 days. I would like to ask what is CPD and what is CPDA?
does anyone know the full form?
Sir, CPD means citrate, phosphate, and dextrose, sir. CPDA means citrate, phosphate, dextrose, and adenine, sir.
Yes, good.
So within 4 hours of the issue of the whole blood, it needs to be transfused.
Nikita, can you also tell what does that AS stand for?
I actually suddenly don't remember, sir. I read about it, but
Dr. Ashok, if you can help us out.
I think sure. I think you should have added that SAGM, I think.
Anyway, homework, Nikita.
SAGM.
yes, sir.
Please look it up and put it up on the group.
I think it is SAGM, where saline, adenine, glucose, and mannitol is added, where the shelf life of the blood unit increases by 7 more days. Actually, usually we store for 35 days. When we use SAGM solution, we can store it up to 42 days. I think that is SAGM. I don't know what exactly is that, AS1, AS3, or AS5.
Yes, sir.
Usually the two. Hello.
Yeah, please go on, Dr. Ashok.
Yeah. Usually the two anticoagulants or blood preservatives used are either CPDA or SAGM. So CPDA she has mentioned. I think AS. I think it is SAGM, where we can use store for 42 days.
Point taken, sir. Yeah, please carry on, Nikita.
Yes, sir. So what is the trigger for the transfusion of the whole blood or PRBC is generally in case of active bleeding or HP being less than 7 or being less than 8 in cardiac or neurosurgery patients.
No, ma.
Yes, sir.
I think that is wrong. I think this 7 is correct, but for the cardiac patients, it is up to 10 usually.
Yeah, I agree with that. Clinically, for people with cardiac comorbidity, trigger must be 10.
Okay, sir.
Yeah.
Indications right now they are just active bleeding, and as sir mentioned, in the case of non-availability of blood components and mass casualties and exchange transfusion. In our hospital, the whole blood is mainly done in case of exchange transfusion. So red blood cell concentrate, packet cell volume is less than or equal to 80%, and 1 unit of PRBC increases the hematocrit by 3%. And after issuing within 24 hours, it will be expired. Trigger being the same as before, the 7 HB being 7, or the patient being symptomatic. There are different types of red blood cell concentrate. They are leukocyte reduced, in which there are less than 5 lakh WBC in 1 unit, and
Not 5 lakh, man, 50 lakhs.
Yes, I'm sorry, sir. Frozen PRBC, which can be freezed up to 10 years, and there are other types like deglycerolized and washed PRBC, and irradiated varieties are also present. The indications of transfusion of PRBC are depending upon the hemoglobin content, and seen in mostly chemotherapy patients who are undergoing chemotherapy, and trauma victims, patients who have undergone surgery or who are about to undergo surgery, and end-stage renal disease, premature infants, and sickle cell cases. This is the three-bag technique, as sir mentioned before.
Okay, 1 second, Nikitha, can you just go back to the previous slide? What is the shelf life you told me?
Sir?
Shelf life of a PRBC. Did you understand the question?
Yes, sir. Yes, sir.
How many days that PRBC bag can be stored? That is the question.
Yes, sir.
You already know the answer, no? 32 days or 35 days, and the other one was 42 days.
Yes, sir. 21
Already
days.
I mentioned, no. If it is a CPDA bag, 35 days. If it is a SAGM bag, 42 days.
Do you know what the shelf life actually stands for? What exactly happens beyond those days? If you store it for beyond that many number of days, what is going to happen?
Sir, generally the changes which to occur are change in the pH and damage to the cells, sir.
So what is that cutoff? What is shelf life taken as? Anyway, I'll give you the answer. Do you know the answer, or shall I give it?
No, sir. No, sir.
Okay. Basically, shelf life is the point up to which 75% of your RBCs are intact. So we do expect some amount of lysis. If it is more than 25%, that means if less than 75% of your RBCs are being lysed, then you can't use that PRBC. So that is what the shelf life cutoff is. All right. And Vinod, are you there?
Hello, sir.
Can you hear me, Vinod?
Yes, sir. Yes, sir.
Yeah. So we kept on talking about this trigger. Forget about the indications. At the end of the day, it's only this hemoglobin less than 7. We need to transfuse.
Yes, sir.
Okay. Why less than 7? Why not 8, 9, 10? Because we know the normal level of hemoglobin is supposed to be around 12 to 14, correct?
Yes, sir.
So why should we wait till 7? Why can't we give blood at, let's say, hemoglobin 9 or 10? What's going to happen?
Sir, basically, less than six. Generally, the cardiac the overload to the heart and these things will be happening more, sir. And during these 10 to 6, these conditions, patient can be maintained with the blood, but because of the transfusions, there might be chances of these allergies and reactions and these things. And we can also increase with the medication, like iron and these things we can improve when the patient is not symptomatic.
Anybody else? Pavan, Indraja, would you like to add on to whatever answer Vinod has given? He has given an appropriate answer.
Yes. Sir, I don't know exactly, sir.
Okay, see, basic common sense, okay? The whole idea of an RBC is to deliver oxygen, correct? So whenever this hemoglobin is less, the amount of oxygen delivery is also less in the blood. So to compensate for that, the heart is working double, all right? Or more, the effort on the heart is more, and so that it can pump more blood and do more number of cycles in order to deliver that much amount of oxygen to the tissues. And please understand, when you transfuse blood for a patient, by the time it gains that capacity to deliver oxygen, it is going to take it about 24 hours. So as soon as you give blood, it doesn't mean that the oxygen delivery is going to start immediately. It's going to take 24 hours. So for those 24 hours, you are overloading the heart. Okay, that is one point. That is what Vinod was trying to tell you, that you can overload the heart when it's already overburdened. That's the first point. And second is that, like we discussed about shelf life, right? There is some amount of lysis of the RBCs. So when these RBCs lyse, the hemoglobin, what is inside, comes out. So there is already some amount of iron which is there in that particular bag of blood, apart from what is there inside the regular RBCs. So this iron is taken up to a certain extent by the transferrin in the blood, but there's still a lot of free iron left. Whenever there is a lot of free iron left, it is a sort of trigger for infection. All right, they say that the chance or the risk of E. coli infections and all are much higher. So to avoid all these complications, they've kept that trigger at less than 7 or less than 7. That is when you need to transfuse. Up till then, please wait and manage. And they've also found that in spite of giving blood, also the oxygen delivery is not going to improve between 7 to 10. So that's the reason you should wait and not jump or be in a hurry to transfuse patients, especially in wards when we see chronic wounds and all. You're like, oh, let's give blood, the wound will improve. It doesn't.
So Nishant, it's actually I think you're right. Basically, if you look at the normal hemoglobin values of men and women, it is, on an average 13 to 15 in women, 14 to 16 in men. So you take a 14 as the figure, and half of that will be 7, because as you said, the heart has to work twice to actually deliver the same amount of oxygen to the peripheral tissues.
And just one more point which Nikitha left out, each unit of PRBC, how much does it increase the hemoglobin by?
1, sir.
Who gave the answer? Pavan?
1 gram per deciliter, sir.
Correct. So the second point, what I want to tell you guys is, whenever you transfuse blood, this idea of giving 1 PRBC doesn't work, because you're just going to increase it by 1. If the hemoglobin is less than 7, ideally at least 2. Okay, it's not a hard and fast rule, but preferable to transfuse at least 2 PRBCs at a time.
Nishant, another thing is the oxygen dissociation curve shifting to the right will happen about 48 hours after transfusion. So ideally, the effect of your blood transfusion is seen at 48 hours. So if you are planning surgery, no point giving surgery the day before.
Thank you, sir. Lakshman, sir, anything to add, sir?
No, that's fine. That's all there is to it. Yeah.
Yeah, please carry on, Nikitha.
So, sir, in that case, the immediate post-transfusion CBC or is, I think, is it relevant, sir, then?
It is relevant. See, your CBC will only tell you how much hemoglobin is there, but it will not tell you the oxygen carrying capacity.
Okay.
That is what we're trying to tell you. Just looking at the number on the paper is not going to help the patient unless it does the purpose what it is meant to.
Okay, sir. So next is platelet concentrate. There are different types of platelet concentrate: plasma rich platelet concentrate, leukocyte reduced HLA matched platelet concentrate, single donor platelets and random donor platelets and pooled pheresis. Single donor platelets, as sir explained, they're taken from one donor and subjected to pheresis, and platelets are extracted from it. One single donor platelet is equals to 6 to 8 random donor platelets. In the SDP requires pheresis, whereas RDP centrifugation is done. And the trigger point for the platelet concentrate is platelet count. If it is below 20,000, platelets must be transfused. If it is between 20 to 50,000, we need to consider transfusion of platelets. If it is above 50,000 and if the patient is symptomatic, then we need to consider platelet transfusion. Indications are any cancer, bone marrow recipients, post-operative bleeding, and immune thrombocytic purpura. Yes.
No, it's not immune, idiopathic. Idiopathic thrombocytopenic purpura, ITP. But you have not put the most important indication, which is dengue and other related, viral infections.
Hemorrhagic fever.
Dengue hemorrhagic fever.
Yes. Sir.
And I think even your indications were wrong. See, the 50,000, you need to have platelets ready. 20,000 with manifest bleeding, then you may have to transfuse. 10,000, you have to transfuse. Dr. Ashok, please correct me if I am wrong.
Yes, sir. Correct, sir. Correct.
Yeah.
Nikitha, do you have another slide on platelet, or is this the one?
This is the one, sir.
Yeah. Before we go into that, Dr. Ashok, can you tell us what is the difference between storing a PRBC versus storage of a platelet? Is there any special equipment needed? Is there some special technique needed to store the platelets?
Yes, this RDP or SDP, we have to store it in an agitator. Agitator means it is like a shaker. So, because platelet, as we know, it is involved in hemostasis or blood clotting. So, if the RDPs or SDPs are not placed in a shaker or agitator, because of the stasis, platelet clumping will happen. So to avoid that, we have to store it in an agitator. And
Please carry on. Please carry on.
And packed red cells usually we store in a refrigerator at 2 to 8 degrees Celsius. That doesn't need any agitator.
Okay. Dr. Lakshman sir,
You have to clarify that before you undertake any operative procedure, your platelet must be 50.
Yeah, I'll just clarify that, sir. I have a list of indications. I'll get to that point.
So that you have to do. And the second thing we need information on is about the shelf life of a platelet in an agitator and its life in vivo. In vivo. That's something we need to have. Yeah.
Yeah, Nikitha, do you have the answer or shall I give them?
No, sir.
Okay. Second thing, sir, before I just get into it, Dr. Ashok, just one more doubt. So your single donor platelet, is it available only if they get a donor, or if there is a willing donor, you do it, and can you store an SDP?
We can store, but only for 5 days.
Okay.
Yes. If the willing donor is available, RDP and SDP, the shelf life is only 5 days.
Okay.
And SDP is costlier, approximately 11,500 rupees. RDPs from normal whole blood only we can extract, but 6 RDPs are equivalent to 1 SDP.
Okay. Yeah. And the second half of the question, what Dr. Lakshman sir is asking is, what is the shelf life after you have given it? They say that you're supposed to repeat the counts within 1 to 2 hours of transfusing the platelets. So if at all, the point behind asking this question is, whenever you're planning transfusion for a surgery, don't do it on the morning or the previous night, like a blood transfusion, if at all you're doing it. We have already discussed, you're not supposed to do that. So it means you transfuse just before surgery, before shifting the patient, or you can even do it on table, like how you transfuse an FFP, it can even be done on table. Now, coming to the indications of platelet transfusion, let's come in descending order. For neurosurgery or an eye surgery, ocular surgery, the minimum platelet count should be 1 lakh. If it is less than that, then you transfuse. For regular surgical procedures, the trigger is 50,000, like sir said. Less than 50, please transfuse. More than 50, don't transfuse. Then if you're planning any minor procedures, like for example, a central venous line insertion or a lumbar puncture, here the platelet count must be 20,000. It doesn't have to be 50. 50 is for surgical procedures, 20 is for minor procedures. And otherwise, if the patient is stable, he doesn't have any bleeding symptoms, like for example, a dengue hemorrhagic fever, then the trigger is 10,000. So don't rush and transfuse, wait till it drops down to 10,000. Now, again, all this, why should we wait to 10,000? We know that the normal value of platelet count is 1,50,000. Here we are not worried like complications of having fluid overload and all, because the quantity is very little. Why can't we transfuse even at 1 lakh? Vinod, Pavan, and Indraja.
Indraja, ask one of them, otherwise nobody will answer. Indraja.
Yes. I'm not sure, sir.
Anybody else? Pavan, Vinod?
No, sir, not sure, sir.
Pooja?
Sir,
Pooja,
don't.
Nikita, do you know the answer?
Sir, I think because platelets do not have any standing function in the like sir, presence of 1 lakh or 50,000 doesn't make a difference unless and until there is some requirement of platelets. Sir.
No, at the end of the day, it all comes down to complications of transfusion. We don't want to face either of these. Unlike RBCs, these have a higher risk of having those non-infectious complications. We will cover this. Just remember the term non-infectious complications. When we talk about complications, we'll get to this part.
Yeah, there is one more issue. As Nishant said, it's best to give transfusion just an hour before or even during the operation. The maximum life in vivo, after transfusion is supposed to be 6 hours, 6 hours maximum, I'm said, but it's ideally 1 to 2 hours is all you should consider. What is more important is that the body has a tendency to form antibodies to platelets. So if you give recurrent platelet transfusion, the life of the platelets becomes less and less as you increase the number of platelet transfusions. So unless you have a spontaneous bleeding condition or you're contemplating major surgery, do not give repeat transfusions of platelets. Okay, that's the message that you need to understand.
Yeah.
Dr. Ashok, is that okay? Is that
Yes, sir. Yes, sir. Absolutely.
right? Okay, go ahead.
Sir, the other thing is normal life of platelets in the blood is 3 to 5 days. But
Yeah.
what you give is, as you said, 60 minutes or to 2 hours or whatever.
Yeah.
Yeah.
Nikita, please carry on. We still have a lot
Sir,
to
I have
do.
one question for Nikita, sir.
Yeah.
Nikita, for transfusing platelets, do you need to get blood grouping and RH compatibility then?
Sir, in case of single donor and random donor, we do not need any RH compatibility, sir.
Okay.
I'm
ABO?
not. Yes, sir.
What about ABO compatibility, Nikita?
ABO compatibility is also not required, sir.
Okay. I think you need RH compatibility, not the ABO.
Dr. Ashok?
Dr. Ashok sir will help us.
For RDP or SDP, actually blood grouping and RH typing is not required because random donor platelet has very minimal amount of plasma. So that usually doesn't trigger any antibody reaction, antibody mediated reaction. And single donor plasma, so there are two options available. One is same blood group SDP donor. One more is PAS SDP donor. That is PAS is platelet additive solution. When we use PAS SDP, when we consider PAS SDP donor, so any blood group donor can be used because this platelet additive solution, what it will do, it will have a crystalloid solution that will usually, once we separate the platelets through apheresis, whatever the platelets are separated, they will be suspended in a plasma. So this platelet additive solution, it will replace almost 70 to 80% of the plasma. So that means 70 to 80% of the antibody titer is reduced. So any blood group donor can be considered if we are using PAS additive solution. So PAS SDP, it is not group specific. RDP anyway, it is random only, so no group specific. If it is not PAS SDP, yes, group specific SDP donor is required.
Thank you, Dr. Ashok.
What about the platelet concentrate, sir? Does that same work for that also? Or?
Platelet concentrate means it is RDP, random donor platelets. Any blood group platelets can be transfused. Nothing will happen.
Okay, sir.
Sir, cost-wise, sir?
Cost-wise, RDP is around 600 rupees per unit. And SDP single donor platelet is around 12,000, 11,600.
For same, sir, for pass added and without pass added also same?
No, with the pass another extra 700 to 800 rupees extra.
Yes.
Yeah.
Thank you.
Yeah, we may have to go a little faster, Nishant.
Yes, sir.
Yeah.
Granulocyte concentrates, it's a very less used one, and I don't think we have this facility in our hospital, but it's basically it is done by apheresis from the family members or blood family members. When they donate the blood, the apheresis is done and granulocyte concentrate is extracted, and pre-treatment for the patient with granulocyte colony-stimulating factor and dexamethasone is given. And it should be transfused within 24 hours of collection, and it can be stored at 24 degrees Celsius centigrade. Indications be
Neutropenia, basically.
yes, sir. Infection and unresponsive to appropriate antibiotics, sir. FFP, fresh frozen plasma, it should be freezed within 8 hours of donation, and it can be freezed up to 1 year. As I mentioned, between minus 80 degrees to minus 20 degrees. And after thawing or after defreezing, it should be transfused within 24 hours. ABO compatibility is main in this FFP, and the trigger being INR value, which is either greater than 1.5 to 1.6 is the basic trigger. Indications being bleeding disorders, abnormal clotting due to transfusion, warfarin therapy for the reversal of warfarin, and factor deficiencies and disseminated coagulation. Below is the picture which shows the water tank in which the FFP is thawed.
Okay. One second, Nikita.
Yes.
FFP is a very important topic that we can speed up elsewhere. Vinod, why is this ABO compatible?
Plus, sir?
Why is this ABO compatible? Why is blood grouping necessary for FFP?
Sir, antibodies present in the plasma.
Excellent. And Nikita, when it comes to trigger factor, what we follow in clinical practice is 1.3. But a lot of books and a lot of articles mention it as 1.5, and some even mention it as 1.8. They say that no matter how much FFP you give beyond this, it is not going to reduce. It will never come down to 1.
Yes.
Okay, you can maximum is bring it down to that level. You can't bring it down any further. Ravi Shankar sir, any changes to that trigger factor from your end, sir?
No, I think it's right.
Yeah, and one of the most important points here is that you have not mentioned is sepsis. Sepsis-induced elevation of PTINR. Okay, that is the most common indication in our ICU setting. Like either prior to surgery or post-surgery, sepsis can cause ups and down of this INR. Okay,
this is a very important point, because you see somebody in sepsis, particularly cellulitis and large abscesses, we do not normally tend to get the INR, but we must get an INR done in all these patients, because if you haven't attended to an abnormal INR with FFP, when you intervene, even with an abscess of, drainage of an abscess, you can have pretty severe bleeding. So that's something you have to bear in mind.
Thank you, sir. And the only thing which I would like to add to that point is, whenever you have a patient in sepsis with deranged INR, treatment of INR alone is not enough. You have to control the sepsis as well. Source control is extremely important. Unless you do that, no matter how much FFP you give, the INR will not be rectified. So it has to be a side-by-side treatment. Okay, move on. Go on, Nikitha.
Sir, one point, sir. How many FFPs need to be transferred? How can we decide on that, sir? I had one value, sir, which showed 10 to 20 ml per kg body weight.
Correct. That is correct.
So, is that enough, sir? I mean, the only.
That is the correct answer. It doesn't
4
depend.
units at a time, usually.
Yeah,
Yes.
and it doesn't depend on the derangement of the INR. Instead, it depends on the weight of the patient. The heavier the patient, more is the number of FFPs that you need to transfuse.
Okay. Cryoprecipitate, it generally contains the factors, clotting factors, von Willebrand factor, fibrinogen, factor 8, fibronectin. It can be stored for 1 year. Indications being the factor deficiencies and fibrin glue. Plasma derivatives are albumin of different concentrations.
1 second, Nikitha.
Yes.
Just go back one slide. Go back one slide. See, if you think about it, even FFP is a sort of blood product that you're giving to prevent or to correct coagulation disorders. So is cryoprecipitate. What is the difference between the two?
Absence of plasma, sir. We are just only separating the clotting.
Correct. Here you're only
Patient.
taking clotting
For a
factors.
specific group of patients only. Yes, sir.
Correct. And with this, it is more or less, the correction is a bit more faster when you use a cryoprecipitate. And the main advantage is the risk of fluid overload is very, very minimal because you're giving them very small quantities. Just like the difference between whole blood and PRBC. Not exactly the same thing, but that's the concept. Where it's a lot more concentrated, it's a lot more effective. And this is mainly for, I think in an indication you have skipped out, it is warfarin overload can be treated with cryoprecipitate.
Okay, sir.
And one more thing is, it is not group specific cryoprecipitate.
Correct, because plasma is the one which contains the
Yes.
antibody. Here it is not.
Yes, that is removed. Yeah.
Correct. Thank you, Dr. Ashok.
The plasma derivatives are albumin and coagulation factors and immunoglobulin. These are produced in a pharmacological setup. Let's move on to massive transfusion protocol. How can we define a transfusion as a massive transfusion? Either replacement of entire blood within 24 hours or replacement of greater than 50% of blood within 3 to 4 hours, or the volume loss being greater than 25% of the blood volume. So this is the massive transfusion protocol. So I will just go through the steps which includes that. So clinician determines that patient requires a massive transfusion, and the basic routine regarding the blood volume and blood count are sent. They will activate the massive transfusion protocol, and 4 units of RBC and 2 units of FFP are requested. We need to see whether the bleeding is being controlled or not. If it is controlled, we need to stop the massive transfusion protocol. If it does not stop, we need to go for the further transfusions. The main aim is to maintain the aim is to maintain the temperature, pH, lactate, calcium, and the blood components of the patient. And we need to monitor his full blood count and coagulation screen, calcium and ABG every half an hour to 1 hour. The things we are trying to optimize are oxygenation, cardiac output, tissue perfusion, and metabolic state.
Do you have more on this? Yeah, go ahead.
Yes. So initial management is we try to stop the active bleeding point, and surgical assessment is done.
Yeah, Nikita, I think we'll stop because this is a lot more into indications of massive transfusion protocol rather than the confines of this particular talk. Can you just go back one slide? I think another thing is, see, please understand, like we discussed in the starting of this class, we no longer have whole blood. All right. Most of the times it is blood components, and ideal ratio is 1:1:1. For 1 unit of PRBC, transfuse 1 unit of FFP and 1 unit of platelet. That is the ideal one. And the second important point that you need to remember is for the storage of blood, we use citrate. All right. So this citrate is a calcium chelator. So the more number of PRBCs you give to the patient, calcium in the blood is chelated by this anticoagulant. So for every 3 units of PRBC, please give 1 unit of calcium gluconate. All right, you need to replace that amount of calcium in the blood. Okay, Praveen, you have your hand up.
Sir, no, sir. Regarding that ratio, I had out that, sir.
Yeah, it's 1:1:1.
Yeah, cleared it, sir. Yes, sir. Yes, sir. Thank you, sir.
That is the ideal one. Okay, and the rest, whatever Nikita told you, please remember, whatever you're aiming is to avoid the triad of death. Okay, hypothermia, acidosis, and coagulopathy. That's what you are supposed to avoid. All right, we have covered all this when we spoke about shock. Lakshman sir, Ravi Shankar sir, anything to be added, or can we move on to the reactions?
That's fine. Can move on. Yeah.
Yeah.
Go on, Nikita.
Just the alternatives of blood transfusion or volume expanders, growth stimulator, cell growth stimulators, and blood salvage techniques, tranexamic acid in order to prevent the decrease the bleeding, and blood substitutes. These are generally the methods.
Just one point. Tranexamic acid does not reduce bleeding. It is only a stabilizer for clot formation.
Okay.
Stopping or reducing the bleeding during surgery is supposed to be a surgical technique. You either ligate or you apply pressure and wait for clotting to happen. Carry on.
Yes, sir. These are the general measures which need to be taken pre-operative, intraoperative, post-operative period in order to decrease the blood loss. And
yeah, we'll go on, Nikita. Anyway,
yes, sir. Blood analogs are recent advanced techniques show a few blood analogs which are perfluorocarbons and hemoglobin-based products, and some blood mimicking fluids, polydimethylxan, and these are used right now. They are being used for some diagnostic techniques rather than for as a blood transfusion.
What is the advantage of a blood analog versus a PRBC?
So, reactions are reduced more.
Correct. See, the whole idea of a blood analog is whatever oxygen carrying capacity or what the job which hemoglobin is doing, these blood analogs does that. So it is not an RBC which is doing that. All right. So the chance of you having a reaction or that donor versus recipient reaction is reduced when you use a blood analog. But like I said, it is not being used that much in clinical practice, but you should be aware of it. And when they ask you in your exam, please make sure you mention this as well at the end.
Yes. So these are basically the blood composition of the blood and the things which we give by the blood components and other techniques to maintain the cells. Hazards of the transfusion, they're either infectious or non-infectious. In infectious, the most common ones are hepatitis B and C, and human immunodeficiency virus, Creutzfeldt-Jakob disease, human herpes virus 8, malaria, and influenza, and West Nile virus. In non-infectious causes, they can be acute, that is within 24 hours, or delayed after from days, months, or it might be even be years. These are this can also be classified as immune-mediated and non-immune mediated reactions. So acute adverse reactions are acute hemolytic transfusion reaction, which results in kidney injury, chills, death, and fever. Allergic or anaphylactic reaction, and febrile non-hemolytic transfusion reaction, transfusion-associated circulatory overload, transfusion-related acute lung injury. In this, the first three do come under immune mediated reaction, whereas the circulatory overload and lung injury, they come under non-immune mediated. Sir, is that right, sir? Lung injury, is that non-immune mediated?
I'm not very sure. I think
I thought it was immune mediated.
Yes,
Dr. Ashok?
Some literature says it is immune mediated, and some literature says it is basically granulocyte mediated.
Yeah.
Leukocyte, leukoagglutinins, that is what we call. So there is a combination of leuko and agglutinins. There is a combination of granulocyte and antibodies.
Yeah.
So
even that would be immune, in that sense.
Yeah.
Okay, go on, Nikitha.
Yes, sir. These are non-infectious, delayed reactions, sir. Alloimmunization, delayed hemolytic transfusion reaction, post-transfusion purpura, transfusion-associated graft versus host disease, and iron overload, sir.
Okay. Can you just go back to one slide? 2 slides back, actually, when you started the hazards of transfusion. See, the whole idea is it's classified into infectious, non-infectious. Dr. Ashok, can you please enlighten us as to how to avoid these infections? Are there any screening tests done prior to collection of blood?
Yes, I think.
Yes, Nishant. We do actually triple H marker, that is HCV, HBsAg, and HCV. Along with that, syphilis and malaria. Only 5 of the markers, 5 of the tests we are doing. Especially for HTLV virus, influenza, West Nile, for all those diseases, we are not screening actually. So as per KSBTC or NACO guidelines or WHO guidelines, only 5 diseases we are screening, that is triple H plus malaria and syphilis.
Okay. I read this long back when I was a postgraduate. If at all you have a donor who's given blood and it turns out to be malaria positive and you're badly in need of blood to save somebody's life, can that be given under the cover of anti-malarials, or is there any similar situations or similar diseases where you can?
When did you know?
Dr. Ashok, can you please enlighten us about that? Is there any allowance for situations like that?
No.
No. As soon as now these screening tests are done prior to donation, or after you get the blood, you check for all these?
Prior to donation, we do only grouping and hemoglobin estimation. After the blood is collected, we are doing this screening.
The testing is done after the collection of blood. Okay. And if at all you find out incidentally a patient is HIV positive, is this information relayed back to the patient?
Yes, usually whenever any of the things, for example, HIV, HBsAg or HCV, if it turns out to be positive, we usually call the donor. We ask for a repeat sample. We always reconfirm or recheck with 3 different methods. One is usually what we do in our blood bank is, one is rapid CAR test, second is CLIA method, chemiluminescence immunoassay method. Third method what we have to do is by ELISA method. So both samples, first sample, and when we call a donor, we will collect a repeat sample. From both sample, we have to test by 3 different methodology, and even after testing 2 times, if it is positive, then we will counsel the donor and we will refer to nearby ICTC center or gastroenterologist.
Yes, thank you. And when it comes
and all the information what we discuss with the donor is highly confidential.
Excellent. Thank you. Now, when it comes to non-infectious complications, please remember the order is FFP as the highest risk of transfusion reaction, followed by platelet, followed by PRBC. This is the order. PRBC has the least risk of non-infectious or those immune-mediated transfusion reactions. Now, again, that can be classified as hemolytic or non-hemolytic. That FNHTR is febrile non-hemolytic transfusion reaction. So unless you have ruled out other causes. Like for example, let's assume a patient is in sepsis and is already spiking fever. And when you give blood, if there is fever, it doesn't mean that if it is an FNHTR. All right. The definition is in the absence of other causes for fever, and you've given blood and the patient develops a spike of fever from during transfusion up to 2 hours after transfusion. It doesn't mean that it should happen only then. Even after 2 hours after transfusion, you can still call it as a FNHTR. Dr. Ashok, one last question. You told me that the platelets are stored on an aggregator. Now, centers like us depend on outside blood banks. So by the time when we receive a platelet bag and there are clumping seen, would you advise us to go ahead with platelet transfusion or discard that bag and ask for a fresh one?
You have to discard. You have to ask for a fresh one, because usually platelet, once it is issued from the blood bank, it should be transfused within 30 minutes of issue. That is the protocol. If we receive any blood product which is issued from the blood bank after 30 minutes of issue, we are discarding without even informing the ward, because that is our protocol. So if, for example, if we issue a blood or blood product, but somehow there is a transfusion is delayed, and the delay in transfusion is, for example, if the transfusion is delayed, then they have to return the blood bag within 30 minutes of issue. So that is the protocol. If the blood bag is returned to the blood bank within 30 minutes of issue, we can restore the blood bag, and whenever it is required, we can reissue. But if it is returned after 30 minutes of issue, we are discarding. That is the protocol.
Okay.
So if you find anything like clumping, clotting, hemolysis, or anything, you have to discard.
Correct. So students, don't just shake it up and transfuse, because please understand, platelet clumps, once they go in, they themselves act as a trigger factor for consumptive coagulopathy. All right. First of all, the platelet count is low. On top of that, if you put clumps, whatever platelets is left in the patient's body will start joining this clump to form coagulums. All right. So don't transfuse such components. Instead, ask for fresh one. On a lighter note, people like us who are dependent on outside blood bank, ask them to come on roads wherever there is metro construction, because of the bumps, and hopefully that will avoid clumping. Any doubts from the postgraduate? Somebody you want to say?
And one more important point I want to add. If you suspect any transfusion reaction, first thing, you have to stop the transfusion. Then immediately you have to send the complete transfusion kit along with the blood bag to the blood bank. Do not keep the blood bag in the refrigerator, and once whatever the transfusion is there, if that subsides, please don't transfuse it. Don't retransfuse that blood bag. So that is very important. If you suspect any transfusion reaction, you have to do transfusion workup, and you have to send complete transfusion kit to the blood bank. If you want a fresh unit, then you have to send a repeat blood sample for recross matching. Then we will issue a fresh unit which is compatible. That is very important.
Yeah.
So
Dr.
do not
Ashok,
retransfuse.
yeah, that's true. But in addition to the whole blood giving kit and the bag and the works going back, you also expect a blood sample, right, from the patient.
Yes.
Yeah,
Yes.
Yeah. So for the postgraduates, it's important.
One
for you to
EDTA,
know.
one plate.
Yeah, please
Along
specify
with
that,
the
sir.
complete transfusion. Yeah, along with the complete transfusion set, we need one plain sample, that is serum sample, one EDTA sample, and one urine sample.
Yeah. Okay. PGs, don't forget that when you see something like that, you have to have this immediately, record it in the notes and send these things that were specified to the blood bank. Okay, and always call Dr. Ashok, in our hospital, call the blood bank officer and let them know that this is being done.
Yeah.
You have to involve them very closely in these situations. Yeah.
Yeah. Praveen, you had your hand up. Do you have any questions?
Sir, yes, sir. Does the duration of transfusion of PRBC, platelets, and FFP any influence, sir? There is any particular timing to be completed the transfusion process, sir?
Nikitha, do you want to take that answer?
Yes, sir. PRBC is generally, it needs to be finished within 4 hours, whereas FFP, it needs to be sent like within 10 to 15 minutes, sir. 1 unit.
And
I'm not
platelets?
sure about, I'm not sure about platelet concentrate, sir.
No, okay. I think it's the same or it's slightly faster when compared to the FFP. And RBC, your PRBC within 4 hours at a slow rate, but certain times in where you need to rush blood, you're allowed to push blood as well. Use a 3-way and do it, but don't do it too vigorously. Why? Why should you not do it vigorously?
Load on the heart, sir. I mean,
No. See, the patient has already lost blood. You're trying to replace it by giving him a lot of blood. You're pushing it. When you keep doing that sucking and pushing very vigorously with a small syringe, what can happen is you will cause hemolysis.
okay.
Because you're sucking and pushing it in. That should not be done.
Sir, I just have one question, sir.
Go ahead.
Regarding when the blood sample, if we find out there are some viral markers, do we discard that blood sample or do we subject it to any treatment, sir?
That's what Dr. Ashok told. No? We discard the blood.
We discard that blood unit.
And then they inform the donor or they confirm whatever viral markers they have. Like sir said, they will do it at least 3 times, confirm the diagnosis, and then inform the donor.
Yes, sir.
Whether they opt for treatment or not is left to them.
Yes, sir.
Any doubts from the postgraduate so far? We have kind of rushed through the transfusion reactions, but it is more of a medicine topic as to how exactly the pathophysiology happens. But what is important is that you identify that it's a transfusion reaction, stop the transfusion, send all the sample as the entire transfusion kit, 2 samples of blood and urine to the blood bank. Manisha, you have a hand up.
Yes, sir. So are there certain medications that the patient is not supposed to be on, if they're going to be blood donors?
Dr. Ashok, do you have any prerequisites prior to collection of blood?
Yes. Usually the latest guideline says antibiotics should be deferred for at least 14 days. There should be no antibiotics. And if the patient is on like antiarrhythmic, anticonvulsant drugs, blood donation is completely deferred.
Thank you.
On chemotherapy, on chemotherapy or immunocompromised.
And what is the minimum weight and hemoglobin that you take into consideration prior to accepting a blood sample or blood from a patient? Not a patient, from the donor.
45 kgs minimum. So, but usually in our blood bank, we consider our cutoff is 50. So, and the minimum hemoglobin is 12.5 grams.
Any other doubts from the postgraduates?
Any other?
Yes, no. If you say no, we'll go ahead. Dr. Abdul, Dr. Pooja, anything to add on or any doubts?
No, sir.
Any comments?
Yeah.
Lakshman sir, comments?
Yeah,
sir?
I think I'll give the final comments, closing remarks. I think we have learned a lot, actually. It's been a very, very useful session. I would like to particularly thank Dr. Ashok for coming in and enlightening us. I think it was very useful that we had him on board today in the exam, in the teaching session. My comments about the presentation itself, I think the slides are pretty good, but Nikitha, you have to practice in front of a mirror. It's not at all unusual to do that. The flow should be much better. You have the slide on, you have the knowledge, but you're not able to articulate. So I think it's important that you practice it once or twice before you actually give the give this session in the evening program. That's an important thing. Second, for the others here, I agree that we should not waste time with long silences. But you very quickly said, I don't know, which essentially means you didn't come prepared. I think this is an extremely important thing that all of you read upon the subject. We are now publishing thanks to Pooja, we are publishing our program a month in advance. And so you should be able to plan your study and read up and come so that you keep your don't knows to a minimum. All right, that's all I have to say. I think any other question? Ravi, as the HOD, you have any question, any comments?
I agree with you, sir. I think she had prepared well, but she was found wanting on many occasions, trying to express what she wanted to say.
Yeah.
I think that can be remedied by practice. And, so I think otherwise, very good session. Thank you, Dr. Ashok. Very, very thankful for your wise inputs. Thank you.
Welcome.
Thank you, Nishant, for your good moderation. And we'll say good night. Good night, all of you.
Thank you, everyone, and good night.
Thank you, sir.
Good night.
Good night. Good night.
Good night, sir.